Good morning and greetings. Welcome to session one of the Lurie Children's Pediatric Virtual Roundtable Series with the Potocsnak Family Division of Adolescent and Young Adult Medicine. My name is Chad Worley, your moderator for the series. I am the Lurie Children's Physician Liaison for the North and Northwest suburbs. I am joined by my colleagues, Paula Nowak and Julie Kalkbrenner. And in this session, we will introduce you to Dr. Priya Dhar, and she'll be talking to you about sexually transmitted infections. But before we get started, I'd like to let you know a little bit about the Potocsnak Family Division of Adolescent and Young Medicine here at Lurie Children's. We provide comprehensive services to adults and young adults. We accept new patients between 12 and 22 years of age. All patients are followed until their 25th birthday. On the screen here, you actually see one of our buildings, and this is the Lurie Children's Outpatient Services at 1440 North Dayton. And this is an outpatient services location for adolescent medicine, psychiatry, and behavioral health. I'd like to introduce you, in case you're not aware, of our new RAMP website. This is a mental health care reference resource and curriculum for pediatric clinicians. And as you can see, my screen is getting bigger, so I don't know what's going on here, but so I'll just talk you through it. This is pretty funny. But this is a mental health care reference resource and curriculum for pediatric clinician. It is formed by a group of mental health specialists partnering with pediatric clinicians to expand access to mental health care. I highly recommend this website for all of you who are looking for additional educational needs for your patients. So visit ramp at luriechildrens.org. Hopefully my next slide doesn't zoom in and out like that. I would like to remind you all that at Lurie Children's, we are relentless in our pursuit of a healthier future for every child. We exist to help all children reach their fullest potential. Respect all is a commitment here at Lurie Children's. We try to create an environment which all members of our community feel seen, heard, and respected. To act on all racism, discrimination, and harassment, concerns raised by patients and families we serve, and by our staff and volunteers. Before I turn it over to Dr. Dhar for her presentation, I'd like to remind you that this session is being recorded. And we encourage all of you during the session to type in your questions, and we will try to get to all of them after the session for a Q&A afterwards. But without further ado, how about I turn it over to you, Dr. Dhar, and you can start your session, and no one wants to hear me talk anymore. So why don't you go ahead and take the screen and take it over from there.
All right, wonderful. Thank you so much, and I'm happy to be here this morning. I'm just going to pull my slides up really quickly. And I hope I don't have the same special effects that we had at the intro, but if we do, then bear with me. So this morning I'm talking about sexually transmitted infections in teenagers, and I'm hoping that today, you guys will find that screening for STIs and treatment of STIs is really something that can be done in a primary care office. I know general pediatricians are increasingly tasked with talking and doing more at every single visit with short appointment time. So I'm hoping we can also talk a little bit about how to do this in an expedient, efficient way. So we are going to talk a little bit about why this is an important subject, who needs screening, how do we test, and then we'll also talk a little bit about pre-exposure prophylaxis for HIV, otherwise known as PrEP. And then I saw in one of the questionnaires that folks were interested in learning about MPV, which was formerly known as monkeypox. So I'll start a little bit with the epidemiology. This is data you can see here from January to June of 2021. This is the most recent STI data that we have from Illinois. These are the cases just in Cook County. And what I wanted to draw your attention to here is that if you look at the ages of 15 to 19 and 20 to 24, they're making up about 50% of all of the cases of chlamydia in Cook County. So, the age group of 15 to 19 is almost 25% of all the chlamydia cases in Cook County in this time period. You'll see that it's similar for gonorrhea cases. So, we have all the way here on the left side, this is the total cases. This is people assigned male at birth and assigned female at birth. And again, what you see is that the age group of 15 to 19 is almost 20% of the cases of gonorrhea in Cook County. And then for the age group of 20 to 24, it's almost 30% of the cases. I did not list, you might be thinking that, hey, this bar graph, they don't add up to this entire thing. That's because I left out sort of those higher age numbers. As pediatricians, we aren't seeing those ages. And then this is the last sort of epidemiology slide that I wanted to show you guys, just to show you that it is important here. And I'm going to what I wanted you to see here is that if you look at the ages 13 to 24 age group and look at the new HIV infections, so new incidents of HIV, what you're seeing here is that about a quarter of them are in our patient population. So all of it, oh my gosh, sorry. Oh boy. Are you guys seeing my PowerPoint?
We sure are, yes.
Okay, cool. So about 25% of the cases of new HIV infections are in our age group that we see. So I'm going to jump to talk a little bit about screening now. I pulled screening guidelines both from the CDC, but where the AAP has made strong recommendations, I wanted to share those with you as well. I think when I look at the screening guidelines, I just think about that huge packet they send out, and gosh, it is, you know, I've read through them, but it's always, every time I have to look something up, I'm like, oh gosh, there's this huge packet I have to read through. So I'd like to distill it down to these points, but then practically just tell you about how I think about screening for STIs. So the first thing the CDC says is that for folks who are assigned female at birth, it is important to do annual testing for gonorrhea and chlamydia with a vaginal swab if they are sexually active. That is for all people assigned female at birth under the age of 25. I do want to put in a plug here and say that, you know, I think collecting a vaginal swab, like a clinician collected vaginal swab, can, you know, be time consuming. I do like to teach young people how to collect their own swabs, and we'll go over that in a later slide as well. But this is something that, you know, could be done at the annual physical. In terms of oral and rectal testing, that should be offered to men who have sex with men at least annually, says the CDC. And then the AAP actually put in some recommendations for HIV screening, and they say that everybody should be screened for HIV once over the age of 15. So the AAP came out a couple of years ago with a strong statement. And so I have just added this into like the, you're due for your flu shot, you know, all of those things. And that's how I get my primary care patients to get tested for HIV at least once in that space. And then HIV and syphilis testing should also be done annually for men who have sex with men. I'd also like to add in there, even though the CDC didn't, that you know, people who identify as LGBTQ, I would argue, should also have HIV and syphilis testing annually. And then HCV, so hepatitis screening once for people who are over 18 years of age. So these are sort of the recommendations. The way that I think about this, though, is I break it down for teenagers and I say, listen, like, it is really important that we take care of all parts of your body. I usually tell them that, you know, if you're sexually active, it's important that it is consensual, and it's important that you're enjoying it. It's important that it's consensual for your partner or partners. And they are enjoying it. So, you know, adding pleasure, like, people should not be forced to do things because of their peers or because of their partners. So it should be something that's enjoyable. And then it also needs to be safe. And so we recommend testing using all of the body parts that you use to have sex. So if you are using the, you know, vagina or penis, then we do a vaginal swab or urine testing. If you're using your bottom, then we do rectal testing. And if you're using your mouth at all, then we do oral testing. And I recommend typically that they do that at least once a year if they're sexually active from all sites they have used for intercourse. And then if they have like more than one partner, or if they're coming in between for STI testing, then I usually like to make a schedule with them like every 3 months for testing or something like that, so that they're not coming back every 2 weeks. I also worry about young people just getting like overly anxious about it. So that's how I typically, you know, talk to my teens about screening and how to screen. So when we talk about how to screen, I mentioned this a little bit. So for people assigned female at birth, it is recommended to have a vaginal swab done. I will say that if that's really hard for your office, I think the urine testing is certainly better than nothing and is still very good in terms of the sensitivity for detecting gonorrhea and chlamydia. And then for rectal and oral testing, there is a swab as well. I actually like to do patient-collected swabs for the vaginal swabs and the rectal swabs as well. I explained that for the vaginal swabs, you just want to insert the aptima swab about 1.5 inches or to 2 inches into the vaginal canal. And then I just tell them to stir, and I tell them, hey, I just want to, like, you need to touch the walls of the vagina. I don't just want any of the discharge that's there. And I explain to them that these organisms live inside cells, so we need some cells. And I tell them to swab for 20 seconds. The recommendation is 10 to 30. Or I tell them to, sing the chorus of their favorite song twice in their head. To collect that. And then for the rectal swabs, I also, these are very tiny swabs, and I show them that, you just need to really insert those in about 1 inch and then twist them, just twist them there and then put them in the tube. And then the oral swabs, I usually collect those or ask one of our nurses to collect those. In terms of the HIV testing, that is a blood test. We do recommend antigen antibody testing, otherwise known as the 4th generation test. Again, the AAP says if you're 15 and over, this should be done at least once. Your office can also consider some rapid testing, which could be a finger prick that results in about 30 minutes. So if that's done at the time of rooming, then by the end of the visit, they likely will have the result. Because those are AAP recommendations for universal screening, I do think that doing those on the front end can be helpful. I often also ask folks to just collect a urine sample, unsure of whether I'm going to be sending it or not. I usually just say, hey, can you get me urine? And I'll decide if I need that later. And then in terms of syphilis screening, so remember the AAP didn't make recommendations about syphilis screening. The CDC says for men who have sex with men to do this. I do recommend doing it with the HIV testing as well if you're taking blood anyways. And most people are doing the RPR with reflex to the FTABs. And then for hepatitis C screening, there are rapid tests for this as well, but there's also just the blood test for the antibody. Which is recommended. What you didn't see on here is screening for trichomonas. There are no recommended screening guidelines for trichomonas unless somebody's coming into you specifically for STI testing. If you're in an area with a high prevalence of gonorrhea and chlamydia, so if you're located in Cook County, you might want to think about adding in trichomonas testing as well, and that can be done either through the urine or a swab. I'm going to jump to the treatment guidelines now. These treatment guidelines are pulled from the CDC, and the treatment guidelines are actually from just 2021. They came out with new treatment guidelines. So just wanted to review kind of the changes. So for chlamydia treatment, so for cervicitis or urethritis, we have changed from just giving a dose of azithromycin to giving doxycycline twice daily for 7 days. For gonorrhea, they've increased the dose of the ceftriaxone. It's increased from 250 to 500. And for people who are above 150 kilos, they recommend increasing that to 1 gram. I believe that's usually dosed in 2 separate injections as well. And if people have a more complicated infection, so epididymitis, so if it has ascended effectively into the epididymis or into the testicular area, then you want to treat with both ceftriaxone, the same doses, the 500 milligrams and the doxy 100 milligrams for 10 days. For PID or pelvic inflammatory disease, so anybody who has cervical motion tenderness on exam or whom you're just concerned about based on the amount of pelvic pain with a history of STIs in the past or with a current STI, you would want to give ceftriaxone, again, the same dose, 500 milligrams with doxycycline, 100 milligrams. And then they've actually added flagellar metronidazole to the treatment guidelines for PID, and you're going to do that for 14 full days. I think this bottom part of the slide is actually the really critical part, which is making sure that people are not having any unprotected intercourse for 7 days after treatment. is completed. It's also really important to treat their partners in the last 60 days. The way that I do this is I usually ask for the last 2 partners, and we'll give prescriptions for those. But you could also urge them to let their partners know to go to the health department, to Planned Parenthood, Howard Brown. They could come to our office as well. We would just probably appreciate an EPIC message in advance if they're under the age of 25, of course. And then if there's any oral gonorrhea testing, because we've tested from all the sites, it's important to get a test of cure 14 days after treatment. There is no recommended test of cure for chlamydia, and the dose, the treatment is exactly the same as it is for the cervicitis or urethritis, but it seems like it's harder to clear from the oropharynx. So that's why the test of cure is recommended. And then I always say, if you're treating an STI, it's really important to bring folks back in. So I say 3 months afterward, you come in and you get tested for all of the STIs again. So if you have a positive gonorrhea test, you get tested for chlamydia, gonorrhea, trichomonas, HIV and syphilis, and hepatitis C if you did not do it previously. I wanted to also say a word about confidential treatment here. I think there's a lot of barriers to confidential testing and treatment, and even discussions about sexual health now that we've moved to open notes. Just want to urge you guys to use that confidential note tab that you should all have. I try to avoid putting things in the AVS because that appears both in my chart and sometimes in that printout. Depending on insurance, we have the explanation of benefits. And sometimes if you're sending in that doxycycline to the pharmacy, then the pharmacy is calling a parent or guardian, and that disclosure is being made at that time, or there's questions asked at that time. The AAP actually does recommend that folks keep some doxycycline on hand in your office so that you can give that to the young person at no charge. Just knowing that chlamydia is one of the more common STIs that you're going to be diagnosing. The other, if people are worried about confidentiality, I think partnering with our adolescent medicine department, but also Planned Parenthood and Howard Brown Health and the health department could also be helpful with young people accessing treatment. Also would like to put in a plug for other FQHCs like Erie that might be close by to you. And I always like to, even though I talk all about confidential treatment, I also think that, supporting the young person. Sometimes, they're scared to tell their parent, and, we can figure out how to get their parent involved just because the young person might have trouble getting treatment or accessing care. So we always talk about, like, who is it that you can trust? Maybe it's an older sibling, maybe it is the parent and they're just nervous. So keeping space to have those discussions is something that I always try to do as well. I wanted to just pull this screenshot because this is one of the things that I think folks can do. So in EPIC, once you order any test, actually, there's this 24-hour release or manual release only. And for all of the STI stuff, I try to click on this manual release only so that it does not go directly into my chart. And I usually, if I've discussed it with the patient, then I just click the appropriate button here, but that ensures that it doesn't show up in the medical record. I wanted to switch now to talking about MPV, formerly known as the monkeypox virus. I think this is something that a lot of people were just really worried about, especially in the summer. And this is one example of what it could look like. And what you'll see is it can also look like molluscum. It could also look like herpes if you see a few of them, and it could also just kind of look like a pimple. So, and in a teenager who has, in whom they could have acne or getting a whitehead here and there, it could absolutely look like that as well. So what I want to say is that it's important to have a high index of suspicion. These are a variety of other pictures that I think I took these from actually NBC.com when they were, just headlining and talking a lot about MPV. These are the different stages of it. And typically you are supposed to see all of the lesions in the same stage. However, sometimes what we saw clinically is that they were in different stages of maturing. But basically what you want is only when it's scabbed over are people fully not contagious or cannot spread this. It is a virus that is mostly sexually transmitted. It is spread through the infectious source. So again, once they're scabbed over, that's when we worry less about transmission. We used to be very worried about respiratory secretions. We know that the viral DNA is actually much lower in the respiratory secretions versus from the sores. And then in terms of things to remember, it is a viral culture similar to the HSV swab. So the swabs that come in that red medium that are often refrigerated. It's really important to use PPE. Think about infection control, Page Lurie ID or a Northwestern ID. And then if you see somebody who on whom you're very concerned and you're seeing a lot of these lesions through located in one area throughout the body, then that's when I would actually think about treatment for high risk disease. That can also help with decreasing how long those sores are there. It decreases pain overall and decreases transmission. I think the more important thing to talk to our patients about is vaccination. This vaccination is still being distributed. It is a 2-dose intradermal, similar to the PPDs that are given 4 weeks apart. And the CDC says to give it to people effectively with high-risk sexual activity in the last 2 weeks. So that would be anybody who's had more than one sexual partner, is a commercial sex worker, or has been to a bathhouse and had intercourse there, or if there was an event wherein it was known that there was a lot of MPV diagnosed there. Those are all the folks that should get vaccinated. These vaccines are available at most of the FQHCs. We do not have it at our adolescent medicine office. And then I think I'm running out of time, so I'm going to say just a few words about PrEP, because there are new guidelines that came out about pre-exposure prophylaxis for HIV. I think the biggest thing to remember is to inform all adolescents about PrEP. So instead of deciding as a clinician whether you think your patient is high risk, talk about it with everybody. The things that I typically tell people is that it is very effective if used appropriately. So meaning if you're taking the pill every single day, it is very effective at preventing HIV. There are very, very few side effects. And probably the biggest thing is that you have to come to clinic every 3 months to have an HIV test. At that visit, all of the STI testing is usually done, but we do recommend every 3 months. And I say that's the only thing I'm going to hold you to. Like, I need to see that negative HIV test. I'm going to skip these, but the CDC, if you are interested in starting PrEP, you can certainly look or take a screenshot of this chart. It tells you all of the blood work to get and at what intervals. You can also, some of you guys have paged our department and said, hey, I really want to start PrEP. Can you guide me through it? We are absolutely happy to do that. As well. There are 2 different options. The one that I would focus on, though, is Truvada, which has been shown to be effective for all-bodied people. And I just wanted to put in this PrEP for Illinois that helps with subsidizing the cost of PrEP, of confidential PrEP for teenagers, so younger than 18 years old. All right, and please reach out with any questions. And I see that there's a few in the chat, so I want to get to those.
Yeah, thank you, Dr. Dhar. This was a great presentation. We really appreciate you coming on and doing this. So yeah, like you said, you saw some questions in the chat room. So what I'll do is I'll hand this over to Julie Kalkbrenner, and she'll go ahead and ask the questions for you as they come in.
Great.
And I'll let you go from there.
Thank you, Dr. Dhar and Chad. So we do have a few questions from one person. I'll read the first one. Do you test asymptomatic individuals for pharyngitis, for GC/CH? I'm sorry, I'm not a clinician, and I don't remember when you referenced that. Or only, you see the question, or only symptomatic who are having unprotected sex?
Yeah, so I do screen people, from the oropharynx if they are reporting that they are having oral intercourse. And that's because there's actually very little known about the transmission from the throat to genitalia. So we're just not sure how, we're just not sure. So I do actually end up screening when I'm just doing the other testing as well. It's actually only recommended to do a gonorrhea screening, but because the gonorrhea and chlamydia tests come together, we end up getting information for both. And that's why we treat then the chlamydia as well. But the test of cure is only recommended if you diagnose gonorrhea.
Okay,
And I can read the next one if you want. I have
sure,
them.
thank you.
We don't have a way to test for gonorrhea on a pharyngeal PCR. The chlamydia comes with it, even though there isn't a recommendation. Do you have a separate test for these? No, I use the same gonorrhea and chlamydia test that everyone does for the other sites as well. So it's usually the Aptima tube, which I believe at Lurie is the white one. And just do it just like a strep test. But no, I do get information on both. Then if you don't have doxy in your office, is it okay to give the 1 dose of azithro? Yes, I actually still sometimes am giving the 1 dose of azithro. Taking doxy for a week, twice a day can sometimes be hard to do confidentially and can also just be hard for people to remember. So I think it is, treatment with the azithro 1 gram is certainly better than not treating at all. And I certainly still do it. And sometimes, I actually recently had somebody who could not take doxycycline who had oral chlamydia, and I actually gave azithro for that. And I'm not really sure that how effective that is, but I do think that there is some probably some effectiveness still, even though the guideline changed. And I think there's one more question.
Mm-hmm.
We know that not all history. So the next question is, not all teens feel comfortable telling us about their sexual history. So we start screening all kids 15 and over, regardless of reported sexual history for gonorrhea, chlamydia, and HIV. Is that overkill? I think, you probably have the data for your office. So maybe, what I would do is look and see like, hey, we screened all of these people who said that they weren't sexually active, and how many STIs did we pick up? I think that's one way of looking at it. I think the other way is to say like, hey, if I make this protocol, then when I need to, when I'm actually concerned about somebody, I don't need to worry as much about confidentiality because patient and family are all already used to giving a urine sample and, doing the HIV testing. So I don't necessarily think it is overkill, but I think depending on your patient population and what you're seeing, you probably have more data around that. I think that certainly does make sense. In areas, if you are ending up treating a lot of STIs there, or even some portion of them, then I think your office could decide that, just knowing that these tests are also, cost money. Can you say more about confidentiality when the bill goes to parents? Yeah, so when the bill goes to parents, I actually do, I often just tell parents like I screen, like I'll tell you, like when I'm doing like birth control prescription, I often am doing a gonorrhea and chlamydia test as well, if they haven't had it done recently. And I do just tell them like, listen, because we're doing this is just like my protocol. I do a pregnancy test, even if you've never had sex. And I do STI testing from the urine. I think if, you can absolutely say that it is part of your clinic's protocol to do that, just to reduce the number of questions. And I think also to building those systems. I think oftentimes, this becomes an important topic because it's hard to do if it's not at the top of our mind. So the more we just create a system for it and actually do make it a protocol, it could help. So maybe Dr. I don't want to mispronounce your name, Minier, has the correct way of just like, let's screen everybody at the age of 15, or at least collect urine samples from everybody. Alrighty, I think those are all the questions that I see here. You guys, you have my contact information, and I also put in on the last slide information for our clinic. We'd be happy to help, walk you through any of these.
Dr. Darwin, someone wants to make an appointment to see you. What's the best way to do it at this point? Is it go through KidsDoc, My Chart, or should they call in a referral to adolescent medicine office?
I think putting in the referral and having KidsDoc schedule is probably the best way. I will say, if you are worried about somebody actively who needs treatment, then certainly just shoot us either an Epic message, or you can just call our office directly, and we would want to get those folks in a little bit earlier. If they need confidential treatment, we are able to provide that as well. So I would just shoot us a message if you have like concerns on that end as well.
Okay. Hey, it looks like Dr. Unger did a follow-up to her question, and it says, so would that be 15 or older?
The state of Illinois says that at age 12, that people can start to access confidential reproductive health care. So, if you would want to start doing that at an earlier age, then I think that would be acceptable. I think age 15 is also fine, because that's when the AAP recommends the universal HIV testing.
Excellent. Thank you. And that will be our last question we're able to take this morning. But one last question for me. Telehealth visits,
Yes.
those are available, correct?
Yes, absolutely. Those are
Excellent.
available. And if folks need to come into the office afterward or need aftercare, then we also, instruct them to go to our office, and our nurses do a lot of sexual and reproductive health care work for us.
Okay, that is wonderful. So I just want to thank you one last time for joining us today and putting on this very informative session that due to our attendance, you could see that was much wanted by everybody. So I'd like to thank everybody for joining us today. I'd like to thank Dr. Dhar for being here and putting on this great talk on sexually transmitted infections. And I'd like to invite everybody who is online now to join us at 12:30 today for session 2. And that's with Dr. Lisa Simmons. And she is going to be talking, identifying and screening for suicide risk. And I know that's a hot topic with many of our pediatric providers out there. So please, I encourage you to join us. And then lastly, this session was recorded. I will be sharing it with you at the end of the week when the sessions are done. I encourage you to share it with your colleagues who are not on our email list, who can get a lot out of this. So thank you for joining us this morning, and we will see you at 12:30. Have a great day.